Going to be looking at medication administration, right? So under this medication administration, look at the rights. We are meant to talk on dosage calculation, but we are not going to focus on that, right? Maybe I'm going to bring out another day for that, and then we'll look at the route and site for medication, and then we are going to look at the Z-tract. Z-tract way of giving medication is a way of giving IM medication, and then we'll look at those high alert drugs, and then we'll look at error that can occur during medication that needs to be reported. So these are the stuffs we are going to be looking at for today's class. All right, so let's dive in. Okay, so when we look at the right of medication, remember that is the foundation of the that is one of the foundation of every safe med. Are you following? So for a medication to be safe, we need to make sure we obey the rights. We have so many of them. We have about 9 of them here, right? So the first right is usually the right patient, right? So you want to make sure you identify the patient that you want to give this medication, right? So there are 2 ways we can use to identify. You can either use the name or the date of birth, or you can use the name or their medical record number. Each patient will have a assigned medical record number to them. So it's very, very important that before you administer a medication to a client, you want to find out whether that medication is for that patient. That is what we mean by the right medication. So it's very, very important, because if you don't identify the right medication, the right patient, you might carry another medication for another patient and administer. This is going to cause problem. Are you following? Now the next one is the right dose. We all know this, right? The right dose. So you need to make sure you check the label and then check the prescription, the doctor's prescription. You want to make sure it tallies. Very, very important. The next one is the right drug. The right drug simply means you're giving the right medication. You don't want to go and give another medication. Let's just say they wrote ceftriaxone and then you went and go and give penicillin. This does not make sense. Then the right route. So you want to make sure you give it on the right side of the body. Insulin subcut. You went and give the insulin IM. You didn't give the right route, right? Then we have the right time. It's very, very important. The medication is TDS. The medication is TDS. You obey TDS. That is 3 times daily. Morning, when it's morning, make sure it's 8 a.m. you give it. If it's in the afternoon, 2 p.m. you give it. And if it's in the evening, 8 p.m. you give it. Not that 8 a.m. then you're giving it by 12 p.m. You're not obeying that right time. Are you following? Then we're looking at the right documentation. It's very, very important. After giving, you have to chart the medication you have given. It's very, very important. Don't chart before you give. Most of us used to do this in order to save time. It's not correct. You need to make sure after you finish giving, then you go ahead and chart. Right? So this is going to help to prevent error. And some of us, you see some people, you see them, maybe they prescribe IV metoclopramide or placebo. Let's just say placebo IM 25 milligram, and then accidentally gave 50 milligram. They'll go and chart 25 milligram. That is not good, right? Then another right is the right reason. Always know why the patient is receiving that drug. Some nurses, when doctor will just prescribe, you just go and give. I'll give myself an example, because I've had a scenario whereby a doctor prescribed ceftriaxone for a patient that is having suspected head injury. The client came in, and then after I saw the prescription, and when I saw this patient, I saw that this patient is an abused client. An abused client. This is how to do. The husband kicked her on the head and the rest of them. I don't know how the doctor clacked and then decided to give ceftriaxone. I didn't give that medication. I had to call the doctor. Then he was not saying he was not this, that before he did not prescribe hydrocort and other ones and the rest of them. So that is the thing. Always know the right reason. Just don't give medication that because you feel like doctors, sometimes they are wrong. Some of them used to make mistakes. They're also human being like you. That's the reason why in the hospital section, it's not just only one healthcare team. We have so many members. Why we have those members is at each point of time care is passes through one team member to the other. We can be able to identify potential error or even and correct it. So that is the thing. Always, that's the reason why you need to know your pharmacology, because when you know your drugs and the rest of them, by the time doctor prescribe these, and then you'll be able to challenge it, right? It's just like the other day I was on social media, and then a doctor put it was just a comment, you understand, I know he was trying to be silly, he knows what he was doing. He now put that he had a Parkinson patient, and then the patient was vomiting. He placed the client on metoclopramide. You understand? So if you know the action and the mechanism of metoclopramide, if you're that nurse, you will not want to give that drug to that patient, because you know that is going to worsen that Parkinson. Because metoclopramide is a what? Metoclopramide, which is your placebo, is a D2 antagonist. It blocks dopamine receptor, and in Parkinson, dopamine is low, and we are giving it to patient that is having Parkinson because the person is vomiting. It's going to worsen Parkinson. It's going to worsen it. So the right thing for us to do is for us to use other forms of anti-vomiting, such as your promethazine can help in that scenario. Are you following? So that is the reason why knowing the reason why that patient is receiving that medication is very, very important. Just don't be that nurse that doctor prescribe it, is always correct. You carry the thing and go and administer. We call those type of nurses gallipot nurses, right? That is what the new generation nurses call them, gallipot nurses. Nurses that they don't know the reason why they're giving that medication. All they know is they follow doctor's order. I'm not saying not to follow doctor's order. Most time they can be wrong. So you're there to correct them. So that is the thing. You let them. Anyone that you know that you're not really so clear, you can learn from the you can learn, right? It mustn't be that you must when you ask them they are wrong. It might be you're also wrong. You also learn from it. That is the thing. And now the next one is the right response. So you want to also, after giving this medication, it is very, very important for you to evaluate the effect of that medication on that client, whether we're having a therapeutic effect. Therapeutic effect simply means a desired effect. Let's say, for instance, a patient is having headache and then they prescribe acetaminophen, and at the end of the day patient says the headache stopped. This is a therapeutic effect. You also go for you to evaluate for adverse effect. It's very, very important, so you know whether the medication is not working the way it's meant to work, right? Let's say somebody is placed on acetaminophen and the next thing they are complaining of a right upper quadrant pain. You're going to suspect the what? The liver might be having problem with hepatotoxicity due to that acetaminophen. So this is an adverse effect. You need to report to the healthcare provider. So evaluating for the drug and watch for adverse reaction is very, very important. And the last one is here, right to refuse. Yes, because a patient can refuse, especially a competent patient has the right to refuse a medication. You don't need to force them. All you just need to do, you educate them. Mr. Jones, you're refusing your medication. All right. If you refuse it, it's going to cause this, it's going to cause this, it's going to cause this, and the rest of them. You educate them and then you document the refusal. And after you finish educating them, still they refuse not to take the medication, document it and notify the healthcare provider. Right? You don't want to force them, because remember the principle of autonomy. The client has their right for every treatment they want or not. So what you want to make sure you obey and adhere to what? Autonomy. It's very, very important. Obey them. They have the right to refuse or take any form of treatment. Now, when we look at the various routes, what are those various routes we can give medication, right? We have the oral route, right? Now, when we look at oral route, this is one that the client swallows orally, right? So it goes through the GI tract and it gets absorbed, right? And from there, it goes into the blood stream. One thing about oral is that it usually is contraindicated if the client cannot tolerate water, because if you can't drink water, you can't swallow that medication, right? So we give oral with water, except if the client can't tolerate orally, can't drink water, we can't go through oral route. So before you give them oral medication, you need to check their client's ability to swallow. If the client can't swallow, there is no need. Now there are some medications that you can't crush, right? There are some oral drugs that are enteric coated. Enteric coated simply means when they go into in your stomach or your GI system, the body releases them small in order to avoid toxic effects in the body, right? So by the time you crush them, this can lead to toxicity. So there are some medications that are enteric coated, so you don't want to crush any oral medication. It's as simple as ABC. Now the next route is sublingual. Now, sublingual is one that we place under the tongue in order for it to be dissolved, because when you place medication sublingual, it's going to bypass what we call first pass effect. It goes directly into the bloodstream. Now, I'm going to explain what is first pass effect. Now, this is the thing. Have you noticed sometimes, it's not like sometimes, if you notice, I'm going to ask a question there so that you'll be able to respond to me. What is the normal dosage? Like now, if I want to give paracetamol oral, what is the dosage for adults? Who can just type it for me? I want to know. What is the normal dosage for oral paracetamol? Like somebody wants to take paracetamol, an adult, like for headache and rest of them. What is the oral? Thank you, 1000 milligram, right? Good. Now, if we want to give it IV, what is the dosage for IV for paracetamol? If we want to go IVly for paracetamol, what is the dosage for paracetamol if we want to go IVly for that same headache? If we want to give it IVly, what is the dosage? I want to ask. I'm waiting for that. What is the dosage we can use IVly for paracetamol? I want to use this to explain first pass effect. IVly 1000, no? IVly, what is the normal IV for paracetamol? What is the normal? I've never seen one. 500. Do you know IV paracetamol? Have you given IV paracetamol? Does it come in 500 milligram? I don't know. Thank you. 600. It comes in 300 milligram per ampoule. So we can go 300 or 600, but the maximum I've seen is 600, most common. I've seen 900, that is 3 ampoule, but it was in a condition like that that the doctor prescribed that. So let's say 600, right? Now oral is 1000 milligram, that is 1 gram, and then IV is 600. Have you asked yourself, why is it that oral tablet is always higher dosage than IM or IV? Have you asked yourself, why is it that oral tablet is always high in dosage, but IM and IV or even subcute, they're not always high in dosage? The reason why is because of the liver. Remember, when I told you, I used to say this, the liver is very, very powerful. When I let just say like now, I carry food and I call a student. Blessing, how are you doing? I'm fine. Oh yeah, take this food and eat. Boss, thank you. God bless you. Blessing will eat the food. As Blessing is eating the food, the stomach does not know whether that food is poison. Blessing herself does not know whether that food is poison or not, right? The body will not know that food is poison or not until that food is being digested. Once it's being digested, the food you eat, before it gets into your bloodstream, like goes to the brain, goes to every part of your body, circulates that food that you ate, before it gets digested and the glucose, the nutrient goes to all part of your body, they pass it through the liver, through that hepatic portal vein. Because the stomach, your GI system will absorb it through the hepatic portal vein and put it through the liver. Are you following? So the liver will not be the one that will not analyze and check that food whether it's toxic or not. If it is toxic, the liver will start releasing enzymes. That's why you see those liver enzymes will not be high in your blood. They are not high for no reason. The liver will start releasing enzymes, trying to convert those toxin to less toxin, so that what? The kidney can be able to get rid of it out of the body. Are you following? so the kidney can be able to get rid of it out of your body. Because if the kidney try to excrete toxic substance, it will fail. The liver is one that helps to convert it to lesser toxic, and that process of converting toxic substance to lesser toxic substance, that is what we call metabolism. That is what your liver does, metabolism. That's why you see some people, they might eat poison and then they will survive it because their liver is still healthy. And that's why you see some people, they will eat poison, they will die because their liver is not really healthy, or their liver was working but the poison was so much and their liver failed. That's the reason when you see somebody that does not consume alcohol and then you give them like a little bit of toxin, and then you see a chronic alcoholic person and you give them a toxin, the person that doesn't consume alcohol, the liver will be able to work effectively to excrete that toxin. That of alcoholic patient, the liver might fail because alcohol damages liver. The liver helps in metabolism. So when you now take this 1000 milligram of paracetamol orally, it's not all of them that the liver will allow to cross. By the time they get absorbed, they will pass through that portal vein to pass through the liver. Before the liver will not allow some of them to escape, out of that 1000 milligram, the liver must have converted like 600 milligram to non-toxic stuff. They cannot work again to less toxic thing. Out of that 600, might just be only 400 milligram that will not escape the liver and enter into the bloodstream, and that will not help and relieve your headache. Now, when you use route like sublingual, IV, IM, subcute, they bypass that liver. That is the reason why when we give, if you notice sometimes, if you give overdose through orally, you see the client who might not have any issue. We used to see some nurses, you see them, they'll give medication orally, overdose, and they might not report to the healthcare provider. You see the client to survive it. You notice nothing will even happen to the client. Be like, I gave this medication overdose, nothing happened. But if you try it IV, you see the client will start manifesting with it immediately, toxic effect with it immediately. Because the IV is bypassing the liver. It's going directly into the bloodstream and it start harming those organs. Are you following? So why I'm doing this is it helps you to understand the basics. That is the thing. That's why we are here. We are not here just to come and teach you, this is this, that, no, this is anatomy, so this is what you need to know. La crème la pomme. No. What this academy is most focused on is for you to understand why it is the basic, because Nclex does not repeat question, but the pattern is still the same. They repeat the same pattern, but the question they don't repeat. It's the same pattern, they'll just rephrase it. That is all they do. So you just need to understand this first pass effect. So that's the reason why when you give somebody overdose with IM or IV or subcute or sublingual, is highly likely for them to have side effect of that medication, unlike in oral. In oral, if you give them overdose, most times if their kidney is very, very good, their kidney will convert every pieces of those medication to less toxic substance. And one of the enzymes that help us in doing this in the liver is that cytochrome P450. It's very, very powerful. That's the reason why you don't want to be using grape juice. Nclex will test it. Like when you're on calcium channel blocker, you don't want to take grape juice. Why? Grape juice go and inhibit those enzymes that will help to convert those medication to less toxicity. So grape juice go and inhibit them. When we inhibit that enzyme, all of them will just cross the liver, and this will build toxic effects within the body. So that is it. So we're talking about sublingual. So when you're using sublingual route, you are bypassing that first pass effect. That metabolism by the liver, you bypass it. And when you bypass it, it goes directly into the bloodstream. That's the reason why, that's how we use nitroglycerin, and it relieves that angina pain. Immediately within 2 minutes or 5 minutes, you relieve the angina pain. It's because of what? It's because you are putting it under your tongue, and that your tongue absorbs it directly into your bloodstream. The capillaries under that your tongue, it's been absorbed directly into your bloodstream. If you take that nitroglycerin orally, it will not work. It will take time. Oral medication take time before it works. That's the reason why when you're having like malaria, let's say like malaria, all of a sudden you take oral medication, you see it might take up to 4 hours, 5 hours before it start really that single dose start working and you start getting yourself. Unlike when you take artemether IM or artesunate IV, within 30 minutes you have already gotten here, start relieving symptoms, will start relieving. So that is it. So sublingual route bypasses that first pass metabolism. So take note of that. Now we also have topical route as well. So topical route is when we apply it under on top of the skin. So it's a local, it can be local, or it can have a systemic kind of effect when we look at a topical route, right? So when we look at topical, it can come in form of patches. We have a nitroglycerin patch, we have scopolamine patch, the one that we use for motion sickness. I used to have motion sickness, so I use a lot of scopolamine patch, especially when I'm backing train. I'm using train, I back the train, I experience motion sickness, so I use scopolamine patch. Then topical can come in form of, say, patch, it can come in form of creams, it can come in form of ointment, right? So when we are using patch, one of the rule of Nclex is that you have to rotate the patch. Maybe if you put it on this side of the day, the next day you have to rotate it on other side. And then before you use that patch, you need to use glove, because if you touch it with your bare hand, because your skin comes in contact with the substance, your skin can easily absorb it. So when you want to wear a patch to a patient, you need to make sure you wear glove. Are you following? So that you prevent your skin not to absorb it. So take note of that. And then you remove the old patch before you place a new one. So that's the thing. Then we can also go rectally. Yes, we can give medication through rectal. This is what we call suppository. So we insert it into the rectum. Yeah, the rectum can absorb medication. So there's some medication that we can insert into the rectum, such as your anusol. We have them, right? So take note of this. So these are some of the medications, the various routes we can use. Now we have the IM and the subcut, right? Now when we want to give IM injection, we usually go 90 degree. That is the thing. Now the safest place to give IM, whether adult or a baby, is the lateral aspect of your thigh. People don't know. People think it's the gluteus. The lateral aspect is the safest. If you don't really know how to give injection, like you're confused or whatever, and you don't want to have any issue, just use the thigh. That is the safest. Unlike the gluteus area, which is the bum bum. So we have so many places you can give IM. We can give it through the lateral aspect. That lateral aspect, the lateral thigh, we target the the vactus lateralis. It's usually very, very safe. I prefer, that is my safest for me. You can also use the ventrogluteal area. That side is also safe too. But to me, I prefer the vactus lateralis. Except the patient does not want, then I can now use the ventrogluteal area. That is this. You can also consider it as also a safe place too. But we don't use that ventrogluteal area if the child is less than I think 7 years. We don't use it. If the child is less than 7 years, I think in my facility we don't use. Some facility will say 7 months. So take note of that, depending the facility. We can also use deltoid muscle. Now, the difference between deltoid and the gluteal area is that the gluteal area can accommodate larger volume, like up to 10 mils. But you cannot inject 10 mils into the deltoid area. That muscle is not so big, so it can't accommodate like 10 mils. Are you following? That's the reason why you see some patient will be like, give it in my hand. Will be like, and then you're like, just imagine like you're giving paracetamol 600 milligram. 600 milligram paracetamol comes in 2 mils. That is almost like 4 mils. The deltoid might not be able to accommodate that. And you know, paracetamol is very, very painful. Yeah, my network. Yeah, sorry about that. I told you my network is a little bit shaky. The network is a little bit bad today, so just manage it. I hope you can hear me now. Adeze, can you hear me now so that I can continue? Can you hear me now so that I can continue? Okay. I think it's from your own side though, because other people are not complaining. Please, can you hear me clearly? Let me know. I think it's from our own network, because my own side is okay. I'm not having any issue here. The network is showing me green. Simply means I can hear you clearly. Thank you. So you can hear it at Daisy. So kindly kind of change position. I think it's your own network. All right, thank you very much. So that is it. So let's continue. So I said the deltoid, we don't use it to give large volumes of fluid. At least less than 1 mil, they can go through that delta. But by the time it's greater than 1 mil, you don't want to go through the deltoid. Are you following? Because it's a small muscle. It can't accommodate large volumes. So that's why we use it for vaccine, because most vaccines are always less than 1 mil. right? Then we have the Vactus lateralis. I've said this one is your thigh. This one is usually preferred in infants because their gluteal muscles have not yet developed. Are you following? Their gluteal muscle is not yet developed. So their thigh is very, very developed, and there is no major nerves in that area. That's why we use it for children. We also have the one we call the dorsogluteal area as well too. This one can also accommodate large the dorsogluteal area. One of the problem is that you can hit the sciatic nerve. This is that one that I told you is very, very deadly. So we have the dorsogluteal area. We have the ventrogluteal, and then we have the dorsogluteal. Take note of the two different. Between ventro simply means anterior, dorso means posterior. Are you following? So the anterior part of the gluteal muscle is safest when compared to the dorsogluteal area, which is the posterior aspect. So take note of that. So we go 90 degree. So don't forget about this. Now when we look at subcute is usually 45 degree. The only time we go 90 if we are pinching the skin. Are you following? The only time you go 90 for subcute is if you're pinching the skin up, you're pinching the skin fold up. Are you following? That is the only time you can go 90 degree for subcute. But if you're not pinching the skin up, you go 45 degree. The most preferred site for subcutaneous injection is the abdomen. That's where we give our insulin and heparin and the rest of them, right? It's the fastest and it's the most commonest site that helps in absorption of the medication. So we use it for insulin, heparin, and the rest of them, right? So you remember, if you're giving insulin, you need to rotate the side, so I will avoid not to have a hyperdystrophy or lipodystrophy, right? Then you can also use the upper arm too. The posterior aspect of your upper arm is an alternative site for subcute. We used to use it to give subcute as well too. Or you can also use the thigh too. But take note, on the Nclex, when they're looking at subcute, you always use that abdomen. That is the side, the left side of your umbilicus, the right side of your umbilicus. The umbilicus is in the middle aspect, right? So that's why we're looking at the abdomen. So take note of that. Now, if the client's skin is thin, like the client does not have enough subcutaneous fat, that is when you pinch. Are you following? You pinch the skin for thinner patient, and then if the needle is shorter, you pinch the skin. So take note of that, so that we can get that subcutaneous layer and not the muscle. Are you following? So take note of that. Now, if you look at the volume we use in giving subcute, it's not always much. It's usually range at least 0.5 to like 1 mils. That is usually the volume. We don't use it to give large volume. Now, there is what we call the Z-tract method. So let me see if I have a picture of it. I have a picture of it. I'm sending it. Now, there is one we call the Z-tract method. Now, Z-tract method, we use it to give medication in order to prevent the medication from tracking back through the needle into the subcutaneous tissue and then leaking out. You will notice it. Sometimes you see, if you give like a artemether, you know artemether is oily. If you give it artemether, after giving artemether and then remove the needle immediately, if you watch at that area, you see the artemether will be as if it's coming back, it's coming up. You see it on top of the skin. We must have noticed this when we give injection. When you give artemether, right, in the bomb, you will see in that gluteal area, and then you put the needle. Not only artemether, some medication, if you remove the needle immediately without not applying pressure, this is not blood. You notice medication will start seeping out from that place you punctured in order to give that injection. Now, Z-tract method helps to prevent that not to occur, because there are some of them that will seep out. They're in the muscle, they will not be seeping out, they will not come into that subcutaneous area. It will not damage the subcutaneous tissue. There's some medication that are very, 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 very toxic to the subcutaneous area. Example of medication, those medications that are very, very harmful to the or painful to the subcutaneous tissue, that is those medications that we use Z-tract method to give, such as your what? Iron. When we are giving iron, IM, that's how we use it. We have to use Z-tract method. Hydroxyzine. Remember, your hydroxyzine is an antihistamine as well too. So we use the Z-tract method in giving hydroxyzine. So take note of that. And then some vesicant fluid, some just vesicant injections. We use the what? We use the Z-track method so that it will not damage the skin. So how do we do that Z-track method? Look at that picture. The first thing you want to do, you want to pull the skin. You pull the skin. After pulling the skin, this is going to displace the skin and the subcutaneous tissue, right? So you pull the skin laterally. You're going to do it away from the injection site, and then you hold it there. Can you see it? Look at that picture I sent to you. Can you see how the person pull the skin, then laterally, pull it laterally, and then hold it, right? Then once you do that, the next thing you're going to do is you inject. So you now inject the needle at angle 90 degree into the muzzle, right? So when you're injecting, you're doing it slowly. So you're injecting it while you're holding that skin fold. You have pinched the skin and then you pull it laterally. Are you following? And then you now inject. After you finish injecting, you will now wait and then withdraw. So you will hold the needle in place for about 10 seconds after injecting, and then you will now withdraw the needle. Once you now withdraw that needle, you will now release that skin fold. You will now retract the skin back. Are you following? You will now retract the skin back, and it will what? It will spring back and then now seal that needle track. Try it, you see. That's what we call the Z-track method. So we use it for giving medication that are irritating or staining or painful to the subcutaneous tissues. So we don't want them to come into the subcutaneous tissue. Are you following? So I've given you an example such as your iron, we call it iron dextran, we have the hydroxyzine, and then some viscous medication. So take note of that. Now, after you finish giving this Z-track method, please, because I know don't massage. Don't massage the site. Don't massage the fat, because when you do that, it will force the drug into the subcutaneous tissue and it will cause irritation. Are you following? Don't massage the site. So take note of that. So that is it for the Z-track method of giving a IM injection. So now let's look at high alert medication. This is to come out on the Vic-Nclex. Vic-Nclex will ask you, the nurse is caring for blah 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 blah. Which of the following are high alert medication? In our Vic-Nclex question bank, you're going to see this type of question. Yeah. Right? But it's not a high level question. I didn't set it as a high level question. I think it's a level 2 question. So take note of that. So let's talk about high alert medication, right? Now, high alert medication, these are medication that bears highest risk of causing damages to the patient when error occur. That's what we call them high alert medication. They are what? They are medication that causes high risk. If you make a mistake in administering the medication, it will lead to a harm to the patient. Are you following? That's what we call high risk. So what is high risk medication? Simply means you need 2 nurses to double check before you administer. You need what? You need 2 nurses to double check before you administer. I will come again for some of you complaining network. I say high risk medication, these are medication that can cause significant harm to the patient when we give it early. So for high risk, for high alert medication, you need 2 nurses to do what? To double check. It's just like when you want to give your blood, right? 2 nurses has to cross check to make sure the blood matches with the recipient and the donor. Because if you go and give that blood, it doesn't match, you know we are going to have transfusion reaction. And transfusion reaction, if you don't identify it early, patient death is going to occur. Are you following? So that is why we look at high risk or high alert medication. So they don't need independent check. You need to double check them. What are the example of high risk or high alert medication? Insulin. Because a little overdose of, if you make mistake in overdosing the insulin, it can lead to hypoglycemia. And you know hypoglycemia is an emergency on the Vic-Nclex. Remember your signs and symptoms of hypoglycemia, right? You're going to be cold and clammy, such as what? Tachycardia, hypotension, diaphoresis, shaking, there is tremor, right? These are signs and symptoms of hypoglycemia. So insulin is a high alert medication. Another one is your anticoagulant, heparin, warfarin, and those direct oral anticoagulant. Example of your direct oral anticoagulant, you're looking at your enoxaparin. Right, we have the enoxaparin is under that. We have another one, those are low molecular weight heparin, they are under direct oral anticoagulant. Those ones are the ones that we take orally. You have enoxaparin, you have the rhizoclinical ban, and the rest of them. So when you are giving heparin or warfarin, you want to double check. Two nurses has to check the dosage so that we cannot give what? Overdose. And this will lead to what? Bleeding problem for the client. And if it is underdose, it will cause clotting. So that's why it is a high alert medication. Another one is opioids. Yes. Just look at medication that any slight thing you make can cause problem for the patient. If you give opioid overdose, patient is going to sleep to death. Coma. Client, you're sedating that client and the client can sleep to death. So that is it. So you need opioid is another one. Chemotherapy is another one. Most chemotherapy drug has a narrow therapeutic index. I've explained therapeutic index. When we look at therapeutic index, in therapeutic index simply means the dose that it will cause a therapeutic effect and the dose that will cause toxic effect is very, very close. It's very, very close. It's very, very close. So chemotherapy, it has a narrow therapeutic index. Example of a medication that has a narrow therapeutic index is your digoxin that we use in heart failure. Digoxin has a narrow therapeutic index. Lithium carbonate has a narrow therapeutic index, because when you look at digoxin, the dose that is going to cause effect is usually from what? 0.6 or 0.5 to 2.0. This is the therapeutic dose, right? So anything greater than 2.0 is toxic. So from 0.6 to 2.0 is very, very close. The same thing with your lithium. Lithium is what? 0.6 to 1.2. Are you following? So take note of this. So chemo is very, very, and when we have chemo toxic effect, most time is irreversible. Then another ones are some of your electrolytes. Yes, potassium. When they tell you to go and administer potassium, your potassium it usually comes in a fluid, potassium chloride to a patient. We don't give potassium IV push, and then the nurse go and give it IV push. This is going to lead to deadly arrhythmia, right? So we usually dissolve it in normal saline, and you want to use an infusion pump to administer that medication. So potassium, some of your electrolytes, they are high alert medication. Then another one is some of the neuromuscular blocker. Yes, some of your neuromuscular blocker are high alert medication, because if you give a neuromuscular blocker it can paralyze the patient. It's very, very important. It can paralyze the patient. No neuromuscular blocker, you're paralyzing the patient, but the patient is not sedated, and this will cause problem for the patient. So take note of these high alert medication. One thing about them, that they need a second nurse to independently verify their dosage, the drug itself, the calculation, whether it's calculated, the infusion pump set, the patient identity before we administer it, right? So that is it. It's not just only one nurse that will do it. We need a second nurse to verify. So this is what we call high alert medication. Now let's look at medication error reporting. What happens when an error occurs in a patient? When you're administering medication and then your patient, what happened? Your patient is going to come first too. Take note of that. When I'm administering medication to Mr. John and then I made the mistake, I gave overdose, these are errors, something happened during that medication administration, my patient comes first. Remember Vic-Nclex safety, right? My patient comes first, then the system learns from it. So your patient comes first simply means you're going to assess that patient first. You want to check their vital sign, check their status immediately, make sure the patient airway is okay, and the rest of the patient safety always come first before documenting. Patient safety come first what? Before you go and document. Then by the time my patient is safe and the rest of them, I will notify the healthcare provider. You report the error to the prescriber immediately, so that we'll know whether there's intervention that will be needed, whether we're going to give antidote before the side effects start coming. You mustn't wait for the side effects to start. Whether we're going to give antidote, whether it's going to require continuous monitoring, or it's going to require for any treatment and the rest. So you want to get that order immediately while you'll be anticipating for the what? For the effect, side effect. Then by the time you've gotten the order, that is when you can now chat. You now record the objective, everything that has happened, the medication error, what was given, when did it happen, what response did the client respond to the medication. Then at the end of this error, you will now file an incident report. Take notes, an incident report is only filed by the person that witnessed it. E.g. now, I witnessed, I did the error, right? Then I'm handing over to the morning nurse. The error occurred in the night. I'm now handing over to the morning nurse, and I tell them to help me and write the incident report. No, the morning nurse can't write incident report for me because they did not witness it. They were not there when the medication error occurred. Except if they were there, that is the only time they can be able to write it. If they are not there, this is a rule on incident reporting. If they are not there, they don't have the right to write. So you have to complete a separate incident report, the occurrence, based on the facility protocol and the rest of them and everything. Do you know why we do incident reporting? It helps in quality improvement. What is going to happen is what? The facility will now look at the surrounding, the thing that caused that error, and now that is where they cannot develop a new policy. That's how policy forms. That is how policy are formed. That is how they will not develop a new policy, maybe so that what? That same error cannot occur. Let's take, for instance, the error occurred due to administering heparin. Let's say patient went and the nurse went and gave heparin, and then the heparin was excess. The facility might not be like, on no account should a nurse give heparin. The medication should be cross-checked by a second nurse. That is how when we are giving opioids, all those opioid narcotics, that was how the rule came about. It was due to error. Like maybe the nurse used to steal the narcotic, right? Or there was an overdose of the narcotic. That was how the rule came about, that before a nurse give a narcotic, a second nurse there must be two nurses there present when the nurse is withdrawing the narcotic. And if the nurse did not give the narcotic and wants to waste the narcotic, two nurses must be present, so that the second nurse will, yes, I saw her, I witnessed it, she wasted the narcotic, she disposed it, she discarded it, she did not keep it for herself to take, because narcotics are medication that are what? That are banned. People abuse it easily. I've had a scenario whereby a nurse used to steal pentazocine from my former hospital. The thing almost cost us a problem. She steals the pentazocine and then she sells them. I don't know to who, to all these people that abuse drugs on the streets. So take note of that. So another thing you want to do is you disclose the error. You want to be honest, especially with your patient. Let them know, and then the family member. It's very, very important. You have to let them know. Transparency is the one key. When I don't know, this is what I used to look at here. When I approach anybody and the person tell me I'm a nurse, first thing that comes to my mind, I'll be like, at least I've met someone that is transparent. Except if you prove otherwise. That is me. And I've noticed that when you tell somebody I'm a nurse, you see, one thing they'll look at it that, yes, this person should be a transparent person. Except you now prove what otherwise. So take note of this. So that is it on Vic-Nclex That is it on medication administration. So this is just a wrap. You might ask, how is this important in Nclex? You will see it. It comes out on the Nclex. They will test you on it. You see it on fundamentals. It's just that they don't come direct. It's usually twisted. You're gonna see it. Which of the following, the nurse is trying to administer iron. Which of the following method should she use? Z-track method. You see, it comes. The nurse is administering a medication through Z-track method. What is the rationale behind using Z-track method? I've explained it. Comes. These are areas that you need to answer in order to push you up. Are you following? So no high alert medications. Because some of you that is even you see this high alert medication is in our what do they call it again? Our assessment, Vic-Nclex assessment 1, the 120 question, our Vic-Nclex. You see that, and some people used to fail it because I view from my own and people used to fail it. So these are the things, it comes out. So these are the things you need to know. All right. So this is where we are going to be stopping it today. So I'm done with my own part in fundamentals, right? So when we meet on Wednesday, by special grace of God, we'll look at pharmacology on Wednesday. Wednesday that is coming. Then upper week, we are going into our musculoskeletal system. So that is it. So it's a wrap. So do you have any question? Do you have any question?